Hey everyone, and welcome to the Balanced Bodies Blueprint. I am your host, Vinny Russo.
And I am your co-host, Dr. Eryn Stansfield.
And we're shifting gears from all the conventional fitness narrative you hear on most fitness podcasts, as our main emphasis lies in preventative healthcare, adopting a holistic approach to nutrition, and challenging the traditional views on various fitness topics.
Our mission with this podcast is to provide you with the information you need to achieve optimal health.
And on today's podcast, we have a very, very special guest. I hate to say it, but it is my wife's professional crush. And it might just, it's not just his intelligence too. He keeps himself in really good shape. So I can kind of see the allure there. But yeah, we have Dr. Karl Nadolsky on our podcast. I've been trying to get him on for a very long time, and he is very, very busy. So he finally found a little bit of time to squeeze us in. So we are very, very grateful to have you on our podcast.
Absolutely. Glad to be here.
Great. So why don't you just give a quick, brief rundown of who you are, so our listeners have a better idea if they don't know who you are already.
Yeah, sure thing. So as it stands right now, I am a general endocrinologist, so specialize in diabetes endocrinology and metabolism. I work in Holland, Michigan, which is actually where I'm from. My clinic is literally now embedded in a big gymnasium here. It's called the Diabetes and Endocrine Clinic at the Gym. And a little bit of my background. So I grew up in Holland, Michigan. A lot of my life was basically focused on sports and school. So I was like kind of a scholar athlete. That was like what I did. My parents were teachers. My dad was a wrestling football coach. He was a biology teacher. So I did have this extra interest in biology. Same with my younger brother, who kind of followed in my footsteps a lot of those ways. Went to Michigan State, was on the varsity wrestling team for 5 years, I guess. And then I actually stayed on for a year to act as the strength and nutrition coach for the team while I had to still get some extra credits to go to medical school. So then after that, went to medical school down at Nova Southeastern in Southern Florida, did that with a Navy scholarship. So after that, I did my internal medicine training residency program for 3 years at Naval Medical Center, Portsmouth. I was a staff internist for a couple of years, during which time I was part of that first class of the American Board of Obesity Medicine in 2012, because I had that special interest in obviously obesity and metabolic health. And then I went on to endocrinology fellowship at Walter Reed National Military Medical Center up in Bethesda. And I was faculty for a couple of years there, did some fun stuff in the Navy. We had a good run, but thought it was time to settle down and decided to come back to my hometown of Holland. And then I was part of a big conglomerate for a while, but felt like it was kind of time to actually do my own thing and do what I want to do for patients. So here I am.
Awesome. Well, thank you for that information. So D1 wrestler, you said 5 years. Did you redshirt your first year?
Yeah, so I redshirted my freshman year and then 4 years. Got into the starting lineup my redshirt freshman year, and then was the starter at 149 pounds for 4 years. Had some ups and downs, and overall, good career. Yeah. Nothing that keeps me up at night. Don't worry about it. So.
So with your background and all the schooling that you did, you obviously keep yourself in extremely good shape. If people haven't seen your photos on the internet, you should go take a look, because he is definitely a doc who lifts. So how did you manage that? How do you manage to be able to keep yourself in such good shape as well as do everything how busy you are?
Yeah. So this really, I think, kind of comes back to what I really, really, really try to preach to patients. And I've kind of molded this sort of mantra more as I've aged, and that's consistency over complexity. Just absolutely finding a way to stick to any routine. We actually, on our podcast recently, we had a behavioralist talking about habits and routines. And I'm like real into definitions of words. And we always say, well, what are your diet habits and your exercise habits? And she actually said that, well, technically those aren't habits that you just kind of do automatically. Those are routines that maybe you can get into some habits that help you with that. And I thought, oh, darn it, that's amazing, because I'm very anal about the language. And so now I actually use that with my patients. But, it certainly helps when you've been doing it your whole life. Right. And I was going... Yeah, yeah. So I was going to the gym to lift weights when I was a little bitty kid. I got my first weight set when I was 6 years old. It was the Hulk Hogan workout set. I have pictures of me with these little bitty dumbbells and the headband that my parents got me because I was real into that stuff. And then once I was a little bit older, like I said, my dad was a coach. Back in those days, we just had one of those old little universal machines, and we'd go up Monday, Wednesday, Friday after elementary school when he wasn't coaching. And I do my little routine for those years, and that stuck with me all the way through middle school, high school, obviously at Michigan State, where you did a lot of that. And then I just tried to stay in some consistent routine all the way through medical school and residency. And, there are days where it doesn't work out. Try to be active, try to be, do anything for physical activity, but finding a way to sneak it in as your day can allow is a big part. So sometimes now having my clinic in the gym, I mean, I'll go down for a 10-minute lift, and it also helps that I have so much experience that I know exactly what to do when I just have a few minutes, you know what I mean? And I know that's harder for some people who don't have a lot of experience, but that's also why they need people like us and our exercise specialists and stuff who can help them come up with like little programs that they can, get some of those personalized efforts in.
Yeah, I love that you said trying to fit it into your schedule, because that's basically like what I do with the clients. Is like everything's worked around their schedule to make it not so difficult to adhere to, right?
Yeah.
And I remember just recently, so a client reached out and was like, "Hey, like working out in the mornings, the only thing I could do, I get up and I could go, and that's the only time I could do it. But I just saw someone talk on social media, with Instagram, that if
I knew it.
work out
I knew this
fast,
was coming.
if I work out fast, as a woman, it's gonna hurt me." I'm like, "Listen,
Right.
don't worry about those. You're stepping over dollars to pick up pennies. Don't worry
Yes.
about that. Like if that's the only time
And
you
that's
can
at
do
the
it."
most. And I might know exactly who said that, who we actually had on our podcast to try to sort of discuss it with her and sort of debunk it. They get into cortisol. So that gets into my world, right? Because your cortisol goes up as you wake up. It peaks when you wake up. That's normal. If that doesn't happen, that's a big problem. And it happens when you exercise anyways. And high intensity exercise certainly spikes it. So a lot of these people say, "Oh my God," because they think cortisol is bad. It's not bad. Having a tumor
it's a necessity
that makes too much is really bad. Being on medicines that's too much is really bad. Being chronically stressed out, sure, there's something to that, but like, no, exercise whenever you can is very good. There's no data to say that morning is worse than later. There are some very subtle nuances for performance in there, but but otherwise, yes.
Gen Pop.
Absolutely. Get it in when you can get it in, and it's good for you.
Yeah, great. And now, being that you're so waist deep, no pun intended, in obesity medicine, what's one belief about weight loss that you had early in your career that you now think was wrong or sort of incomplete?
Yeah. Well, I'll tell you, the most glaring and obvious one is that if you would have asked me 20 years ago, I thought I could fix everybody with diet and exercise. Absolutely. Sure thing. Thought for sure all they had to do was do what I do, and I'll teach them how to do it. What I didn't know at the time that I was able to learn, because and I'm open to learning stuff, is that it's a lot more complicated than that. And general obesity, most obesity is a very polygenic disease. It's very heritable. There's a lot of risk factors genetically for it. Doesn't mean everyone will succumb to it, but there's a lot of complex genetics behind it. And then we say that the genetics load the gun, but environment pulls the trigger. Well, of course we have this obesogenic environment, and then everyone's different. Everyone has different background. I was very lucky with my background in this stuff, and parents that certainly nurtured it, but not everyone has that. And then you throw other monkey wrenches in life, and different things, medications, illnesses, injuries, in addition to all the genetics and the environment. And and I didn't realize that. And so I've had to learn, and that's why we are advocates for medical and surgical therapy as necessary to help people achieve whatever amount of weight loss they need to improve their health. And that's really what it's also all about, right? So it's literally either preventing or treating obesity related diseases that we care about, and that's mental, metabolic, and physical obesity related diseases that we want to make sure we're helping people with.
Yeah, I think that's great. Even I echo what you just said, because when I started medical school in the 2000s, and even during residency, We used to think obese patients just need to try harder. They just
Mhm.
need to work out harder. And even during my training, that mentality started changing. Like, obviously, there's more nuance to it, there's more
Yeah.
complexity, and we can't be, saying this is one cause when we don't actually understand the cause.
Right. So you can have functional practitioners saying that they can figure out the exact root
The
cause.
cause,
Yeah.
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 Yeah,
So
I
it's
think
so
it's so
complicated.
complex.
Yeah.
Yes,
Hmm.
and
Yeah.
there's so much nuance in science, and that's where I think social media gets it wrong, right? That
Yeah,
we don't
absolutely.
recognize the nuance. So my next question has to do with you and your brother.
Okay.
Um, so Spencer, what what is something maybe that you guys disagree on in the obesity space? Because you guys both practice
Yeah.
obesity medicine. Is there something that you guys fundamentally disagree on?
So yeah, and it's subtle because, I mean, I'm 4.5 years older than he was. I did training before him, and so to some degree, I've been a mentor of his for all these years. And then together, we just happen to have a lot of very similar interests. And we both want to be very evidence-based. We don't want to be quacks. And we've always tried to fight against it. We've even had to change some of our trajectories because of that, because of, kind of coming to some of those realizations and making sure we're doing what's right. So there's some subtle things like, for example, one is that, especially a few years ago, before a little bit more of the explosion of the obesity focused GLPs. For example, when we first had semaglutide approved, or Wegovy, the obesity version of Ozempic for obesity, and because it was by far the best one compared to the other medications we have as far as average weight loss and outcomes, and then we knew. We assumed and then were proven true that it was going to have other benefits like heart benefits, kidney benefits, liver benefits, et cetera. And so one of the things that he would always say is essentially GLP or GTFO. You know what I mean? And I've tried, and even in a recent publication that I was the lead author on for obesity management, it's an algorithm from the American Association of
Right.
Clinical Endocrinology. Is that's not always what's appropriate. So that especially at that time, it was the most aggressive, most expensive medical therapy we had for obesity, and not everyone really needs it. And so some people do. So really compelling indications for it would be people with obesity and heart disease, fatty liver, renal disease, et cetera. In the case of, say, tirzepatide or the Zepbound, it has the indication for sleep apnea. And so a couple of the pages in this algorithm that I authored was talking about which medication should be favored if you have those obesity-related diseases, but also for cost effectiveness in people who don't maybe have those strongly compelling indications for the more advanced, expensive therapy, to consider some of our older therapies, and if they don't have contraindications, if they can tolerate them when they try them, and if they respond to them. And so people who respond to we'll call them the first generation medications, if they are able to achieve about a 5% weight loss in the first few months on those medications, they're gonna probably achieve clinically meaningful weight loss of more than 10%, which is kind of the average of them. For one example, a great example is phentermine topiramate. The brand name was Qsymia. There's now a generic version, and a substantial number of people were able to achieve far more than 5%, but even 10 and 15% of weight loss on that. And it was and it still is sort of the next best medication for average weight loss too, of for those who stay in the studies, 10, 11% or so. And that's on average. And some people can respond very, very well to it. And it's cheaper. And there are some off-label ways we can do it even cheaper too.
So
So that's one little, I know that's subtle.
It doesn't just increase your heart rate, right?
No. And in fact, that isn't a big deal, like the phentermine part of that, because it's, people used to think phentermine's been around forever as an appetite suppressant since like the 50s, which is also why it's a controlled substance, because they used to think it was an amphetamine. Well, it's not really an amphetamine. It has some amphetamine-like properties. So some people can feel a little bit, the heart racing, but we keep the doses low enough where it's really just an appetite suppressant. You can get some dry mouth and stuff like that, and it's not addictive at all. So that's why it's now approved and for long-term use, at least in the combination with topiramate.
Right.
Nice.
Awesome.
Yeah.
Thank you for that. And, is there a place, I know that you were involved with this algorithm, besides PubMed, is there a place where somebody could like look at your publication?
Yeah. So if you go, so the journal is Endocrine Practice. That's the American Association of Clinical Endocrinology's flagship journal. And if you just go to AACE.com, AACE.com, and you go to, it's kind of geared towards healthcare professionals, of course,
Yeah.
but anybody can look at it. And I actually think we should probably make a patient-centered, patient-facing version of it.
Yeah, I think that would be useful. And I'm glad that you were involved with the algorithm because I think it's so hard on the clinician side, right? To
Yeah.
know these medications are great, but it's hard to know exactly like who is the patient population that's going to get the greatest advantage and who is it geared towards.
Yeah. And yeah, to your point, I mean, we really need more primary care doctors feeling a little bit more comfortable. Doesn't mean they have to do everything, but just like diabetes. I mean, diabetes is an obesity related disease that's more complicated than obesity without diabetes.
Right.
And primary care doctors generally feel pretty comfortable with that, and then refer to us when necessary if needing some extra help and stuff like that. So that's really who it's for. It's kind of for everybody in healthcare, and then I think patients can get something out of it too.
Awesome.
Great. Yeah. So going on to like me and you right now, real quick.
All right.
So a lot of the posts that you put on your story, I'll tag you in everything.
Yeah.
Maybe you'll put me on his story. I don't know. But a lot of the stuff that you do actually put on your story deals with scope of practice. And one of my things, especially like one of my goals this year is to be like, listen, just try to put out the word, put out a message that reaches coaches to help them stay in their lane more so than not, because now we see crazy things out there like peptide courses for coaches and like genetic reading, like genetic test reading and like how to analyze labs. And I'm just like, this is going nuts because I feel like they have to keep trying to drum up new ways to get more business because they're not good at the basics, right? Like I don't need to go
that's a
that
great
route
point.
I'm pretty good at the basics with my clients. They might not be. So they're coming up with all these new ways to drive new business. So what I wanted to ask you is where do you draw the line between what a physician should handle versus what a coach or nutritionist, whatever you want to call them, can responsibly manage?
Yeah, I mean, so to some degree, it probably does matter what their, clinical context is, like where they're working. So I have dietitians, and one of my dietitians also happens to have an exercise degree of some sort, like a personal training certificate, where I really trust her to take the patients that I have literally and to essentially help them with their nutrition planning based upon what I want, and also help them come up with some sort of personalized exercise routine, either at a gym or at home and that sort of thing. But also I have diabetes educators who I feel very comfortable with, say, adjusting patients' insulin under my supervision. They know not to go crazy, and they know what they don't know. And so to some degree, people have to know what they don't know too, right? And this goes for doctors. You know this. I think some of the best doctors, especially in primary care, are the ones who are like, hold on, I don't really know. I'm going to go ask an expert. So, when I was at the big conglomerate, the internal medicine department was upstairs of where I was, and those guys would come down and talk to me all the time. And I knew exactly who I would go to if I needed help, because I know they're not just going to make up something. If they don't know, they're going to ask an expert or go figure it out. And so I think there's something to that. But for most, dietitians, exercise specialists out there, I mean, for the most part, you really got to stick with what your expertise is. Dietitians can have a wide variety of nutritional expertise, from, micronutrient issues, absorption issues, behavioral, mental health, disorder type things within diet, right? So disordered eating type issues, and then obviously exercise specialists. There's a huge array of different types of background there, though, right? So there are those who maybe did kinesiology or exercise science in undergrad, and then they get more certifications. Maybe they're physical therapists or whatever. And they can have, they'd be very trustworthy to take any patient and teach them an exercise routine, because they're going to really personalize it, make sure they're not doing something that's, going to cause injury or some harm. Maybe have some more understanding of like what medications they're on. Like, my patients with type 1 diabetes, they're obviously relying upon insulin pumps, shots, et cetera, to live. But if they exercise, they have to know what their blood sugar is going to do with that and with the insulin. And so you have to have some trust there. But I mean, anything getting into lab work, medical decision making, diagnoses, medications. These peptides that everyone's talking about now, they're not the approved drugs we have, like say Ozempic, Wegovy, et cetera, or even some of the endocrine things like insulin. Insulin's a peptide. They're talking about drugs. I don't think they realize these are drugs. They're not like some natural supplements that just have
I
maybe
think
some
they
benefit.
realize it, and that's where I'm like, this is
Uh,
medical malpractice. Like,
yeah, they haven't even been researched enough to be approved for anything, and these people are
Yeah.
taking them. I cannot believe it.
Yeah.
It blows my mind. I would never take a drug that it was, who knows what the heck it is.
Yeah,
And there
it's
may be some benefits. We'll see.
Yeah.
Like the BP 157. I mean, I know it's been
Right.
studied in animals and maybe has some human potential for like injury recovery and stuff like that. That's great, but I'm not going to take it right now. And I'm getting old. I've got some stuff that hurts, and but I'm not going to take it because I don't know. I want to see the phase 3 trials that get it approved first before I take
in
it.
humans.
In humans. Yeah, not mice, for the
Yeah.
love of God. God,
Yeah,
it's
I think
amazing.
it's crazy what's out there
It
right
is.
now.
It's
And I'm like, these
insanity.
are medications that are
Yes.
recommending to
Yeah.
people that, and you don't know what the end result is going to be. Are you going to be the person treating them when they have a problem?
Yeah.
It doesn't make any sense to me.
And they speak with such confidence and conviction
Oh,
when
yeah.
they're like, oh, you have this issue, take this, that, and the other thing. It's like, how do you know? And then there's no research in humans. So how do you know the dosages, the
Yeah.
protocols? How, like, where are you coming up? Oh, from your bodybuilder friend who heard it from another
Yep.
bodybuilder friend. Who heard it from,
Yeah.
And then you're playing telephone.
Yeah.
Like it's,
Yeah.
So, but on medications, so many influencers, I'll just broad scope
Yeah.
it there, out there, they peddle the idea that doctors default too quickly to medication. So
Right.
from your perspective, what do these influencers or what are these coaches that kind of preach that? What are they misunderstanding about medical intervention?
Yeah. So, as medical doctors, depending on our specialty, and that I think most people don't realize how many different types of doctors there are. They always say, oh, doctors don't do any lifestyle stuff. Well, there are a lot of doctors who there's no reason for them to talk about that stuff. If you're getting a referral for, something like there's nothing to do with it. But in medical training, even though, we don't get a ton of nutrition, all that stuff in medical school, but again, it's, internal medicine residency, endocrinology fellowship. We have to do extra training and studying in addition to those things.
Yeah.
And so in my life, nutrition was a big deal. Yeah, I had an extra, interest in it too. And obviously the exercise thing. So at the endocrinology national meetings, I do get asked to talk about nutrition and exercise from an endocrinology perspective, to teach other endocrinologists, by the way, so that everyone can do this. On the other hand, that's not necessarily working at the top of our licensure. Let's say we are medical doctors or surgeons, and that's where our expertise really does come into play. We should be the ones doing diagnosis, treatment plans, medications, and surgeries. And in theory, we absolutely should be utilizing our dietitians and exercise specialists and behavioralists and everybody else, the whole team, to help people really flourish in all those lifestyle behavioral things. That gets into system issues, though, because it's not always covered by our, shitty insurance system. And then, and then people are like, the doctors don't do any life. They just throw medications because the primary care doctors only get 15 minutes because reimbursement's horrible if you don't. The insurance system incentivizes poor care and more patients in a day than long patient appointments, which I will just not make a lot of money while I stick to what I want to do and try to build the program around it, because I'm so passionate about it. It just pisses me off, to be honest. But that said, it is our job to do the clinical medical diagnoses, medications, treatments, and surgeries, not necessarily the diet. I mean, we do it. We know we always push it, but a lot of times they don't have time. So they go, hey, you got to work on your diet and exercise. But doctors do that all the time. And then people say nobody talks about it. But I know they do because I see it in notes when I get referrals. I hear about it from patients. They say, oh, they just keep telling me to eat better and exercise. And it's like, okay, well, so now we got to take some other steps to treat you medically for whatever that might be. So it's just kind of ironic that people say that, but I think that's just, again, that's a marketing gimmick ploy to divide and conquer a little bit, because really we should all be on the same team.
Yeah.
We're not, we really shouldn't be working against each other.
A multidisciplinary team, I think, is the best, right? And so
it's Certainly, it's just what our horrible healthcare system doesn't do a good job of
Yeah, I've
paying
been
for that.
lucky with you know, on the preventative medicine side of things, and that I've never had to deal with the insurance side. But then, you know, the way that we run our business, it's more of, so to speak, a direct care model, right? And
Yeah.
so um, that can get expensive for some people, and
Yeah.
unfortunately, you know, not everyone can afford that, and that's unfortunate. I think in our medical system and with insurance is that they don't reward those lifestyle changes. And
Yeah.
so unfortunately there's this conundrum in on the medical side
Yeah.
of like, how do we spend time with our patients and discuss the lifestyle changes and still you know, uh, address their other clinical concerns at the same time.
Yeah.
Yeah,
That
I'll say, well,
yeah,
I don't mean to cut you off, but
yeah,
I'll say that like, even with like what we do, right? Like, I feel like the population that I'm in, right? The coaching field, the coaching realm, there's an insecurity with not knowing enough. And so
Mm.
everyone has to pretend like they're this Renaissance man
Oh, yeah.
that knows a little bit about everything or everything about everything. And it's okay to say like you don't know something. So for example, like she's the internal health, preventative medicine side. I'm the nutrition and movement guy with habits and adherence and consistency and doing all that. When we get into like training, like I have a personal training certificate, but I actually get on phone calls with their trainers and we talk through what my nutrition strategy is, and
Yeah.
we go over like what they're trying to train. So we work together with whoever
Yeah.
they're working with. And she's been on calls with their doctors, with their endocrinologists, and just to make sure everyone's on the same page.
Yeah.
So we all have the same message, right? Because if you are delivering different messages, you're just going to confuse the client. They're not going to know what to do, and you're actually harming them. So
Yeah, absolutely.
yeah.
I don't have a great answer as to how to fix the system. The politicians are, oh God, they just argue, and I don't know. I don't know what's
I
going to
think
happen.
your clinical model is one way, right? Like where you're incorporating your dietitians, you're in a gym. I mean, these are great examples of how to incorporate that. That's why I think I'm a big fangirl, like I mentioned before, because I think you're actually putting that into action. And I feel like if more clinicians did that, we would move more towards those lifestyle changes and give enough credence to our patients to make those changes and to be the example. I mean, you're in the gym, they're working out probably alongside your patients.
Yeah.
If they see that, that's
shit, they
that's
see him
that's
take
a
off his
big
shirt, they're gonna be like, "Let's go."
Yeah.
big testimony, you know, that my doctor's actually doing what he preaches.
Yeah.
I think it's a great model.
Yeah.
That being said, what do you think, given your social media presence especially, is the most dangerous misinformation about obesity out there, that you see maybe on social media or from non-medical people?
Yeah, that's it probably goes back to the stigma of it's their fault. I think that's probably, and now on social media, there's this huge spectrum. There are those, I mean, people think we're just like giving everyone medications. Well, obviously that's not the case. We're like shills for lifestyle medicine, but they don't necessarily know that, I guess. But
You literally wrote the algorithm.
yeah, I'm most proud of our page on lifestyle stuff because I tried to really, anyways, that's a whole thing. But so but I still think there's still so much where people they have to use the word jab, right, for the shots, the medication
Right.
shots. It's always a jab, and they over exaggerate the potential risks. All medications have risks. That's why we need the phase 3 trials and more observational data instead of just taking random drugs that people are throwing out there. But yeah, all medications have some risks, and we need to know those, and we need to follow and study. And sometimes we get burned because there's things down the road, but they over exaggerate the risks of medical and even maybe surgical therapy, and they put the onus all onto the patients. And they're, again, not understanding that it is a very complex, and we'll use the term heterogeneous disease. Everyone's so different. I really think that's the problem. The stigma of making people think that if they can't do it without medicine or surgery, that they're not doing something right.
Yeah.
I mean, they're trying. People are at least trying. I mean, it's easier said than done. That's the thing. The biology is working against a lot of people.
Yeah. Well, and then now there's this other stance of, well, if you do take the medication, that's an easy way out, which I hate
Right.
as well.
Right. It's just not. They're treating the
it's
disease
not.
process. So just quickly, I'll try to do this in a minute, but one of the most recent publications that I show almost every patient, and we did talk about this on one of our recent podcasts, is they did a post hoc analysis of one of the tirzepatide trials. It was like the fourth one, I think. And the basic bottom line is they gave everybody in the trial tirzepatide or Zepbound. And at 36 weeks, the average weight loss, again, everyone's different, right? But the average weight loss was 21%, which is amazing, but
Absolutely.
kind of consistent with what tirzepatide is.
Yeah.
Then they randomized people to either stay on the medicine or the placebo shot, right? So all these people responded. And then they switched to placebo. They don't know that they're on placebo, but the placebo group regained 14% of their weight on average. But then what they did in this post hoc analysis that I thought was so cool is they divvied it up to see, well, how many regained this much, this much, this much.
Oh, yeah.
And about 17% of people didn't regain any weight.
Full amount.
So that means that those people don't have significant disease, of obesity pulling them back up like a spring in their brain, trying to pull them back up. And even like 4%, if you look at the little waterfall plot for individual people, 4% kept losing weight. Now, who knows what else was going on in their lives? It's a study, something may have happened. Maybe one of them got surgery somehow, but I feel like that would have made them get taken out of the study. But then, then most people certainly regained a significant amount of weight. And then I think it was like 25% of people regained all of the weight, almost all of the weight. And then 9% of people not only regained all, but were gaining beyond what their starting weight was. And that group of people certainly had the most severe disease of obesity, so just a huge spectrum of that disease. And I think it just goes to show, it can really prove to people how different it is. They all lost weight on the medicine. And then off the medicine, they all regained differently.
It's interesting because it's so nuanced, right? Within, because we group people, they have certain qualities, and we say, all right, you are in this category of a disease progression or something like that, or a disease. And within that category, there's so many nuances, so many differences, individual differences, but also we're seeing that on a population level, right? Where some people regain more, some people don't regain, some people stay stable. So again, it's so nuanced. So to give any underlying, this is the cause or one thing, it's so much more complicated than that. And I think that people miss that.
Well, I think this is perfect lead into this GLP-1
discussion.
So she was like, I really, really want to dive into this. So let's really make sure we get into this. So to ground us, Dr. Nadolsky, can you just briefly walk us through the current evidence-based criteria for prescribing GLP-1 medications for obesity?
Yeah, so I do like to always start off with people it sounds like these are all new, right? But actually, the first one was approved in 2005 for diabetes. That was exenatide. That was the first one that was twice a day. A few years later, liraglutide, known as Victoza, and then later on for obesity, as Saxenda at a higher dose, was a once a day. Before we started getting the longer acting weekly ones, people may be familiar with Trulicity. That's a relatively recent one made by the same company that makes Mounjaro and Zepbound. And those have been around for a long time. Before we had semaglutide, and then most recently tirzepatide, which is actually a GLP-1 GIP dual agonist molecule. I don't know how much we got to get into that, but the basic indications. So the labeling has changed a little bit, and probably for the better. So going back to like the algorithm that we published, we talk about the diagnosis of obesity being based upon excess adipose tissue, and then the clinical diagnosis being, well, what harm, if any, is it causing yet? And that's staging the severity of disease. And so historically, it was a BMI over 30 or 27 with any comorbidities. Now they kind of took that out because people can have a lower BMI with abdominal adiposity, or they can be very thin with enough weight where it's causing weight related problems. There are some ethnic nuances there. So they actually took that wording out, and it's just, the indication is obesity. But I'll tell you, just from a real clinical perspective, going back to that one slide in our algorithm that I talked about, for example, if you have obesity and you've had a heart attack. Well, semaglutide, Wegovy, was shown to reduce the risk of recurrent heart attack, strokes, et cetera, in that population. So that's a very important one to be on. Now, if you have type 2 diabetes, we at least now have, we can be very comfortable with the Mounjaro Zepbound medication, because what they did, the Trulicity medication, was already shown to have cardiovascular benefits in type 2 diabetes in the past. And they basically just compared it to that. It wasn't statistically superior, but it sure was hinting at, if we had more people and longer time on it, it was probably going to have better cardiovascular benefits, I would suspect. And it certainly has better weight loss and blood sugar benefits, et cetera. So I think in people with type 2 diabetes and heart disease, certainly now we feel very good about putting them on Mounjaro, the brand of it. And I'd feel pretty comfortable based upon that. You know, if Zepbound was the way we needed to go for somebody, if they had heart disease, that'd be fine too. But also sleep apnea. So, Zepbound literally has an indication for sleep apnea due to obesity because of how good it was at that. People who have fatty liver, especially those who are at a higher risk of the metabolic associated steatohepatitis and then fibrosis. So they have some evidence of fibrosis and they have a real high risk of progression. Wegovy has been approved for that now, based upon its trial data and based upon phase 2 data. We certainly would expect tirzepatide or Zepbound to have the same benefits and eventually be approved for that. We could say those with obesity and kidney disease probably should be on those medications, based upon, again, mostly from type 2 diabetes data we have showing the renal benefits. People with, you may have heard of this heart failure with preserved ejection fraction, where it's not the pumping of the heart, but it's just not, it's stiff essentially. And that's a relatively common cardiac complication in obesity. And so they studied both tirzepatide and semaglutide in people with heart failure and preserved ejection fraction, with significant benefits. And I actually think more than like the heart failure type symptoms that they were looking at it primarily, I'm a big fan of the 6-minute walk test. They were able to, with the weight loss, do much more distance on their 6-minute walk test, which again goes back to our exercise, because what's one of the most important treatments for any type of cardiac condition? Exercise, obviously. But if your heart failure symptoms and your obesity are preventing you from doing it, well, sometimes we have to treat the obesity first so you can exercise. Yeah, and so those are some of the most important indications. And then of course type 2 diabetes, pre-diabetes, the diabetes prevention data are sort of obvious. I mean, you would fully expect them to be the best things because they have direct blood sugar benefits. But obviously in type 2 diabetes, they really, if it weren't for a cost thing, they would definitively be, first line at this point.
Everything you just went through, it to me, like I'm sitting back here, I'm just like, because she knows more about it than I do. And I'm just listening to this. I'm like, this is a miracle. It's their miracle drug.
So that's how
I mean, they're pretty darn good. They are good. Yeah.
I guess from my side, from a preventative medicine side, do you ever see the future? Because I see all the clinical trials on how it does so well for, people that have cardiovascular disease, who have fatty liver disease, as you mentioned, as you alluded to. Do you see this as potentially, I mean, this is looking into the future now. Do you see this as a medication that could be a preventative medicine scheme?
Possible. I mean, that is definitely somewhat of a hot topic, I think, at least amongst us, specialists and stuff. And I do hear, this gets into kind of the influencers selling microdosing of this stuff, right? I mean, there's now some of what they call microdosing is essentially homeopathic dosing. It's not anything, it's worthless. but lower doses of these have been studied. That's how they came up with the doses. And maybe I'm not like a really pro drug person. I don't want to take medications if I don't need them and I don't have the true clinical benefit. However, I could see at some point, especially if cost comes down and we have more and more and more data showing benefits over risks in lower risk people, then yeah, maybe, maybe it is something we're all going to want to be on at some point. I mean, akin to maybe like statins, where now they're generic and yeah, it's a pretty low threshold to say, yeah, okay, I'm going to reduce my risk with a statin kind of thing.
Well, I think it's interesting because, the highest mortality risk is among people with cardiovascular disease. And so I'm like, now we have a medication essentially that could decrease that risk potential. So
Mhm.
what, I'm excited to see how this plays out for mortality risk in general.
Yeah.
What's going to be the number one cause of mortality now if we eliminate or at least decrease the risk of cardiovascular
Yeah.
disease. So I'm excited
Well,
for
Number
that.
two.
yeah.
Whoever's
So
number
to
two
your,
is going to jump up.
what's number two?
Yeah.
Do we
No,
know
I
what's number
said,
two?
he says
Oh,
number two is going to jump up.
yeah.
So
Well,
maybe
so off the top of my head, you should. Do you know what number two is? Because
I
is
think
it
it might be
cancer?
cancer. Yeah.
So that's what I thought. So then the next thing is there's so many obesity related cancers. So
Exactly. Yeah.
this is one of the reasons why we say we don't want to wait to treat obesity until you have one of those obesity related diseases.
Right.
Thus, the more severe
Prevention
staging that
side.
we get into,
Yeah.
because there are, we don't want to wait till they have cancer
Yeah.
to,
Right.
to treat it, and anything else. And so, hopefully we're going to be reducing obesity related cancers too. And there are some hints of that in the studies with these medications. It's not probably the medicine itself. It's probably just because we're treating the obesity and reducing the unhealthy adipose volume.
Yeah.
Well, and I want to ask this question before we run out of time, but on the other side of the spectrum, I think, at least I know, um, the risk of the compounded, medications out there, and those are not recommended essentially.
Right.
So please don't get the compounded versions. Please go to your physician to, actually, make sure it's clinically indicated. But we do see those compounded versions in Gen Pop, right? What have you seen as far as like people that might not actually meet the clinical criteria and they're getting a compounded version? Maybe they are not, their BMIs are even normal. Do you see a risk there with, people taking these compounded versions and maybe not actually meeting that BMI risk potential or risk stratification?
Yeah. I mean, potential. I mean, yeah, the compounded thing, again, it blows my mind, but it's purely a money making thing. People think, oh, you're just shilling for big pharma. Not yet. Someday, but that's literally what they're doing, right? So they're doing it to make money, and it's not really legal anymore. I mean, there was a loophole when the supply was out, and boy, they are not. These molecules are complex and patented by these big pharma companies that have put in tons of money and time into research, and then that's where we know the benefit and safety data from, right? And again, kind of going back to, so what else the risk? So the compounding part, that's a risk I would not be willing to take with these medications unless they're generic. When they become generic, then that does open up for true legal compounding of whatever that medication is, right? But just kind of to the risk of someone who doesn't really have any clinical indications for them, I don't know. I think, the more risk, the more severe disease you have. So the more diabetes, heart disease, fatty liver, sleep apnea, the more you have of that, the more dramatic the absolute and relative benefits of these medications are. So then the benefits far outweigh what little risks, but there are risks with any medication. And so if you're somebody who doesn't have any obvious benefits from it, then suddenly that ratio is way different. So I don't have much of a risk of diabetes, heart disease, fatty liver, sleep apnea, I don't think. And so if I took it, I'd maybe be able to stay leaner. Maybe it would be easier for me to stick to my diet. So maybe that is a benefit that could outweigh what little risks there are. But some of the risks that are definitive are like gallbladder stuff, right? That's a real risk. It's small, but it's a true risk. Beyond that, you hear a lot about the eyes and stuff like that. And that's been a concern raised in some of these trials. In the grand scheme of things, I just saw a huge meta-analysis published that really said not a major concern, but that's again, overall, it doesn't mean that a few people here and there don't get a risk. So God, that would be a bad thing to get just because you were taking it for vanity purposes, perhaps. On the other hand, people will argue, and I'm trying to be open-minded, that, we do a lot of vanity cosmetic procedures that have risks, right?
True.
So, that's an argument. I get it. And so maybe it does. Maybe there is some vanity indication for it too. And that's, I guess if that's the benefit risk ratio you want to have, I guess, I don't know.
Yeah. My concern would be more like if you are, a normal BMI, you're, maybe don't need this medication and you're on it and you are seeing the some of the benefits, it would be muscle loss. And I know that
That's where I come in.
Yeah.
Yeah. And literally to your point, I mean, so
Yeah.
anybody on these medications, when oh boy, the now very infamous Peter Attia started raging against the machine when one small subset of DEXA analysis came out of the step 1 trial for semaglutide, he completely overblew the hyperbole because he never actually specialized in anything, but he started scaring everyone away, saying, "Oh my God, it's causing everyone to lose muscle." There's so much more nuance to body composition. It was 100 people out of several thousand. And it looked like it was a little bit more fat-free mass loss than what you would have expected for the amount of weight loss. This was not reproduced in some other semaglutide trials. The tirzepatide trials didn't look like it was a thing. But any weight loss, any energy deficit that's created, surgery, medication, lifestyle, can put you at risk of some muscle loss. 100%. And so the answer is, Vinny, what's the answer?
Resistance training.
Everybody needs to do strength training. Yeah, everybody needs to do it from cradle to grave. No matter what,
positive nitrogen balance with a little bit higher protein and do some
exactly. So strength training most important. Then optimize protein. I mean, and then if you're really worried, like first, so some people with diabetes, they are kind of sarcopenic and they're frail, and we got to be very careful with that. So we desperately need them to strength train. We need to make sure they're getting enough protein, and maybe even some benefits from things like creatine and whatnot. Safe but possibly beneficial. So I mean that is another reason that you got to be careful if you're taking this purely for vanity. Yeah. But even to then, and trust me, I want to tell people not to do that. But if they're strength training and doing all the other things, then really that really shouldn't be a huge concern.
Yeah, that brings up two questions, right? So it throws in my mind something that Mike Israetel said, where he was like, if there was a pill you could take that would replace exercise, hell yeah, I'd take it. Well, everyone should take it, right? And I was like, so from your vantage point, like what proportion of, let's just go with your GLP-1 patients, actually build those habits of nutrition, movement, focusing on sleep, that type of stuff versus those who are essentially just relying on the medication alone?
Yeah, I think, that's interesting. So I'm going to use one example from one of those Wegovy trials where they, in all weight loss medication trials, they have a diet exercise component of both the placebo and the medication arm. And generally speaking, the placebo arm is able to achieve 2% weight loss, which goes to show how effective basic diet and exercise recommendations are. But then each of them usually has like an intensive behavioral therapy study where they show how the placebo does, and that's usually consistent with, say, like diabetes prevention program, look ahead, and their average is like 6-7% weight loss, right? So that's pretty darn good for a lifestyle program. Well, in fact, definitely in all the previous medications, it basically showed an additive benefit. So in addition to 7% weight loss, they were getting another 7 to 10% weight loss in those studies. In the Wegovy trial, interestingly, the placebo arm got their 6-7% weight loss, but the amount of weight loss in Wegovy was very similar to in the other trials when there was no intensive behavioral therapy arm. And so what that told me when that first came out was that these medications are just doing a better job at helping people adhere to the basic diet and exercise recommendations. Yeah. And that all the weight loss is really predominantly dietary. We've gone over that, and you've shared stuff about that. That's another one of those myths where historically people think they got to exercise more for weight loss, and really it's the energy intake that's the problem. And so I will say that especially when we talk about dietary quality measures, that the medication really does help them make better decisions. So the front part of the brain is able to actually make the decisions of what to eat, how much to eat, improve the quality, minimally processed foods, all the things we want to do, rather than letting the rest of the body's biology run amok. And the hunger hormones are up, satiety hormones are down, craving hormones are going crazy. And that's really where it is. So I do think, especially my patients, because I do so much more than probably is expected, dietary discussions, and I have my dietitians. I think most of them, it helps them do all those things. It really does help them do it. And that, I think that's important, especially when we talk about that one trial where if people do have to go off of it or do a different medication, we better make sure they've learned how to change some of the routines, because, you know, there are ways with diet and exercise to really maintain that weight loss, but it's easier said than done in some people.
And
So
it's funny you said that, because like even with my clients, or our clients, sorry, what I noticed is that you get a little bit of progress, it automatically triggers something in them to want to do
yeah,
more.
sure.
Right? So
It's
a cumulative
motivating.
effect.
Yeah.
Yeah.
It's
So it's like,
like,
oh, I
yeah,
can fit in
positive
different clothes.
reinforcement.
Yes.
Yeah.
I can fit in different
Yeah.
clothes. I want to go walk more, right?
Mhm.
I'm feeling so good walking more. Maybe I want to start jogging now.
Yep.
And now I'm feeling confident enough to get into the gym and start lifting weights. And it's like
Yeah.
one thing after another. It's a cumulative
Yep.
build.
Yep. You're right. I talk about this vicious cycle that we have to, you know, kind of pick apart in all these different ways and get it going the other direction. And yeah, the medications can be a really great help for that.
100%,
Yeah.
which leads into that second part of the question, which is, if for someone who doesn't really change that behavior, right? What
Yeah.
does their long-term trajectory usually look like once they lower the dose or they actually come off? I know you mentioned the
Well,
studies that
yeah.
showed like
I
some
mean,
of them
if
come
they
back.
come off and that's the case,
Yeah.
then absolutely the body's biology is going to pull them back up.
Pull back. Okay.
I mean, that's a certainty. When all the studies we've seen, that's what happens. I mean, that's what happens even when they're trying to do all the, you know, the things that they've learned with diet and exercise, let alone if they haven't really changed the behavioral efforts.
Yeah.
Yeah, yeah.
For sure.
Well, and I think those behavioral changes are so important, like that they're the foundation, right? But then, you know, depending on the disease complexity,
Mhm.
then different factors are going to play into that as well.
Yeah.
So I think the behavioral stuff is interesting too. And again, I think these medications are great. I think they are just, to me, I see them as something that might be used on the prevention side
Mhm. Yeah.
eventually.
Eventually, yeah, probably.
Well, I mean, with your background in how Western medicine saved your life, essentially.
I had cancer, and so whenever
Oh.
people like trash Western medicine,
Oh God, yeah.
I am like, no, it saved my life. Like, I think
Yeah.
there needs to be a better relationship. There's so much distrust, right, in the medical
Yeah,
system and
there
with
is. Yeah.
doctors, and so I'm a big proponent of Western medicine, and you know, as you alluded to before, doctors are there sometimes to prescribe medications. That's what we were
Yeah.
trained for, to help people, but we are here to help people in the best way possible, and we use the tools that are going to be more efficient to help our patients, right? And so for me, I'm a big, you know, I'll shout from the
Yeah.
rooftops, Western medicine saved my life. So
Absolutely. It's a great point.
yeah.
And then the last sort of section we want to get in with you, we want to get into, you know, your practice and business model,
Mhm.
just because we both are big fans of it. We think it's extremely important. So I know you
Yeah.
really wanted to dive in some
I was
questions.
just going to say, just, I know we're short on time.
Mhm.
So just give us a basic rundown of how your clinic is different than the traditional side. And maybe you can tell us, I don't know if you're just in Michigan or if you're in other states, but I think it would
Yeah.
be great for our listeners to know. I know
Bring it out here to Utah.
yeah, I know myself, I am often, like, as you alluded to before, that I'm often referring my patients, you know, if they need an endocrinologist, or I think that they might fall in the category of needing a GLP. I like to refer them off to people sometimes, depending on, you know, the primary care people I know in the area and that sort of thing.
Mhm.
So can you tell us your model and where you're at?
Yeah. So again, this is an evolving thing. I want to do so much more with our resources that we have now. So the basic model is still mostly primary care or other specialists refer people for whatever endocrine disorder. And that could range from obesity without complications, or obesity with, say, we do a lot of PCOS, we do a ton of type 2 diabetes, and you know, another fatty liver and all these different things. But also we get a lot of the type 1 diabetes patients. So we have a very focused type 1 diabetes program, and I'm going to have a physician assistant starting with me soon who is open about her diagnosis of type 1 diabetes, and in fact has been my patient and is just finishing up physician assistant school.
That's awesome.
And very excited to have her
That's
because
great.
she's going to be even better than I am at doing type 1 diabetes, because she literally lives with it. And so we're going to have a really focused type 1 diabetes arm. We have great diabetes educators that I've been able to have over the years. I mean, they're really the key, by the way, for type 1 diabetes, especially because they're the tech gurus. We have so much great technology now. And so we have a great system there for the people with obesity and obesity related things like type 2 diabetes. My diabetes educators, exercise person. And I really do want to get, I utilize the gym where we can get them in. Now, the business model of it is, we're doing insurance right now. Or they can pay, they can do direct pay and then get a bill. And, if we don't take their insurance or whatever, and then send that to their insurance company, which works too. But I will say that just because I refuse to let the insurance healthcare system screw my patients, basically, I make sure my appointments are long enough to spend time with them. And it's not lucrative right now, but that's okay, because I feel like, I'm also going to have another physician assistant who's going to be my thyroid specialist. I think physician assistants are really, really helpful when they can work under a specialist and then really focus on something where they can become just as well expertise as anybody else. Sometimes, people might think we run into problems elsewhere where, they start doing independent stuff or whatever. We're trying to give them too much oversight over themselves and all things in medicine, but they're going to be really good at those focused things. I'm hoping I'm also going to have a former diabetes educator who is finishing up nurse practitioner school be my obesity, cardiometabolic, type 2 diabetes follow-up specialist, which will then open my time up to be more of a true specialty consultant, which I love to do. And I spend a lot of time with new patients getting consultations for pituitary, parathyroid, calcium, thyroid, adrenal stuff. But for now, we're just doing all of it together. And I need to have more opportunity to take care of some of those more nuanced, very complex endocrine disorders. And then, hopefully starting next month, we will have a direct care model, sort of a membership model, where people can pay a monthly or an annual fee, where they'll get a lot of long visits with me or the physician assistants, my dietitians, the exercise people. And maybe I can convince the owners of this gym system, that maybe we can have a model where it can cover both. They can get a membership to the gym and a membership to the medical care. But the problem is that gets into business stuff. That's easier said than done, right? And then, so there's a lot of complexities to that, but that would be kind of the dream. But for now, we're basically just functioning as a general endocrinology clinic, but with a lot of obesity, type 2 diabetes, and type 1 diabetes.
Are you guys branching out to different states, or are you just now
going
in your state?
That it takes money to make money, right? So that's what they used to say. So I have my license in Florida, so we do a lot of virtual stuff for people in Florida, mostly because of the kind of the snowbird concept. So my brother is the one who's all virtual, and that's kind of been his thing. I mean, he's the Mr. Social Media. He was able to develop all these different ways to do all social online virtual stuff. So he's like licensed everywhere with his operation that focuses mostly on kind of a primary care aspect of obesity and metabolic disease. But so we'll see. The sky's the limit. Maybe we can have a clinic in the gym everywhere.
I love your model. I think that's why I'm like, are you in other states? Because you need to be, right?
Well, we can make it happen.
We're here in Utah. We'd collaborate. Right. So
let's see if we can figure something out.
There's lots of gyms out here.
It almost reminds you of onsite.
Yeah, a little bit. Yeah. Anyway, we are so excited to talk to you. Thank you for taking the time to chat with us, and thank you for giving us insight into the research and GLPs and your general stance in medicine.
Yeah, is there for our listeners? So your social media, website, where they could go read about you, your articles, whatever. Just lay it all out there.
So the social media, it's pretty much all Dr. Karl Nadolsky. Somehow my little brother stole the Dr. Nadolsky, because he's always so much more advanced into technology and social media than I ever was. And then our podcast website is docswholift.com. And my clinic website is endocrineclinicatthegym.com. And I mean, that's pretty much it, I guess.
Thank you so much for your time, man.
All right. You guys keep up the great work too.
So on behalf of Balanced Bodies, we just want to say thank you for joining us on this episode of the Balanced Bodies Blueprint.
We are committed to bringing valuable content. And if you enjoyed today's episode, we'd greatly appreciate it if you can take a moment and like it and leave a 5-star review.
On Apple, just go to the show, scroll down to the bottom and rate it there. If you're on Spotify, go to the show's page, click the 3 dots, and you can rate it there as well.
And if you believe in the power of knowledge, share this episode on your social media to try and get the information out there to as many people as possible.
And as you navigate your own path towards better health, remember that Balanced Bodies is forever in your corner. See you all next week.
The podcast content may include discussions of medical topics and health-related information. However, the information provided should not be considered exhaustive or complete, and it should not be relied upon as a substitute for professional medical advice or treatment. Always seek the advice of your physician or other qualified healthcare providers with any questions you may have regarding a medical condition or treatment.